A value-based care pathway to improve congestive heart failure, chronic obstructive pulmonary disease, and pneumonia outcomes, a QI project. Abstract. Healthcare systems face rising demands from diagnostic complexity, outdated guidelines, patient expectation, limited resources, and misalignment. We use data analytics and project management to design a clinical pathway for CHF, COPD, and pneumonia. Each step included a sequence of critical steps assigned to an accountable stakeholder, allocated a time box, and tied to deliverables. The care pathway improved vertical alignment and with leadership goals and horizontal collaboration among teams. This led to sustained quality gains, including a greater than 20% improvement in length of stay, better GDMT adherence, cost reduction, and enhanced value-based care. Background: CHF, COPD, and pneumonia are among the leading causes of costly hospitalization. The conditions frequently overlap due to shared risk factors, complicating diagnosis and management. 20% of CHF patients also have COPD, which raises risk of cardiovascular disease, hospitalization, pneumonia. COPD patients comorbid vascular disease increased pneumonia risk, while pneumonia itself is often underrecognized in COPD cases, leading to worse outcomes and longer hospital stays. Average length of stay is 4.8 to 5.4 days with high readmission rates. CHF is 21 to 23%, COPD 19%, and pneumonia 17.9%. Despite proven benefits of GDMT in CHF, COPD, and pneumonia, adoption remains low as physicians struggle to keep up with guidelines. 28% of medical errors stem from individual cognitive gaps, while 46% arise from combined cognitive and system failures. Reflecting this challenge, one-third of New England Journal of Medicine Quality Council members rated the hospital's quality and patient safety as moderate or worse. About 25% of U.S. healthcare costs are wasted, with a quarter of that being preventable through process improvements and better care delivery. Team-based models like integrated practice units can improve outcomes and lower costs but remain underused. To address these challenges, a sustainable solution was designed and implemented. Objective: a collaborative clinical care pathway was developed to streamline care, eliminate waste, provide a predictable clinical course for patients. Such pathways reduce cost, complications, and length of stay. The approach also fosters a culture of alignment where residents practice teamwork, project management, balancing quality, time, cost, and scope. Stakeholders are held accountable for their timely completion of critical steps to achieve key patient deliverables: safe care, swift management, satisfaction, and staying out of the hospital. Methods: PDSA Cycle 1. The methodology was followed. A checklist of critical steps necessary for managing care pathway patients was used on each hospital floor, and every hospital discipline was held accountable during MDRs. 75 patients were enrolled from July 2023 through February 2024. Results showed an optimal length of stay of 3.59 days and 21% readmission rate. PDSA Cycle 2 collaborated with our IT department to build a timed order set to hardwire and automate critical steps. 125 patients were enrolled from March 2024 through November 2024. Results showed a greater length of stay to PDS Cycle 1, but continued to average less than 4.5 days, while 30-day readmission rates increased. Results: length of stay averaged 4.05 days, consistent with CMS target, and a greater than 20% better than the Florida average. 30-day readmissions rate averaged about 25%, which is comparable to Florida readmission rate. Eliminating unnecessary rate resulted in discharging 43% of our patients before 11 a.m. Optimizing consultations had a mild positive correlation with length of stay. Conclusion: building and hardwiring a value-based care model can be achieved by hinging it on a strong foundation of aligned stakeholders, following a data-backed clinical pathway to provide well-communicated, valuable deliverables. Patients are best served with a team that serves as an integrated practice unit that should include ancillary staff to cover patients' active and latent needs. This unit is as strong as its weakest member. Value delivered can be defined by team's value index. The value index increases with higher quantity and decreases with higher cost. Cost reduction is predicted on controlling variable costs, with variability in timing and decisions being the biggest culprit for cost overruns. Our clinical care pathway for hospitalized patients with CHF, COPD, and pneumonia helped us address patients' need as a team and led by medical residents, and resulted in less variability in clinical decisions, higher adherence to GDMT, and a significant reduction in length of stay.